Hello, and welcome to Introduction to Interprofessional Collaboration for Nursing Students. My name is Bethany Dizer. I'm a registered nurse and an adult geriatric primary care nurse practitioner, and I am working on this project with nursing students, medical students, and direct care workers as part of the Dell postdoctoral fellowship out of the College of Osteopathic Medicine at Michigan State, working with the Impart Alliance, an organization that supports the direct care worker profession. And so I'm really excited to get the chance to work with you on this project, and I'm so grateful for you to take the time to learn with us. Brief overview of the program. The goal is to prepare professionals to work in long-term supports and services for older adults. It prioritizes a holistic, person-centered approach to care. The objectives of this whole program revolve around practicing both interprofessional collaboration and the development of your nursing specific competencies for working with older. The structure here, you'll do this brief minute video where we go over some concepts and definitions and strategies that will be helpful to you, and then going into our in-person interprofessional activities. So on the 8th of April, you'll get together with a group of direct care workers to work on some case studies about caring for older adults in long-term care. And then on the 15th, you get together with all the nursing students, direct care workers, medical students, get together and do some unfolding case studies and problem solving and shared care planning. So hopefully it'll be a chance for you to learn something new about caring for older adults as a nurse, as well as practice some new skills about how to collaborate effectively with physicians and direct care workers and other nurses. I have a feeling I have a lot to learn from all of you, and I hope that over the course of this project, you're able to learn something new from some of our topics and from some of your other future colleagues. So let's jump right into our learning objectives. Today, we're just going to quickly define the term direct care worker. We're going to describe the challenges and future directions of a strong direct care worker workforce. We'll define terms like interprofessional education and interprofessional collaboration. We're going to identify the interprofessional collaboration responsibilities of an RN while they're working with direct care workers and physicians. We'll define the concept of person-centered thinking, and we'll relate person-centered thinking to the nurse role. We'll define geriatric syndromes quickly, and then review some interdisciplinary communication strategies. It's a lot, but we'll get right through it. So first, what is a direct care worker? Direct care worker is a paid provider of hands-on care, particularly to older adults and to people with disabilities. Some of the roles direct care workers perform are supporting individuals in completing their activities of daily living or instrumental activities of daily living. They also are active in supporting meaningful community engagement and participation in relationships for the individuals that they work with. The term direct care worker may be new to you. It's a term that's meant to be descriptive and to address a truly independent profession. And it avoids terms that suggest dependency, like assistive, assistant, or aid. So what might you know about direct care workers that you've probably encountered over the course of your nursing education or maybe in your workplace? Direct care worker example jobs, you may know someone who works as a certified nurse's assistant, a home health aide, a personal care assistant, or direct service provider. That's a term often used in like community mental health settings. They use DSP. Direct care workers work in long-term care facilities, private homes where people live in the community. They may also work in daycare services or in supported work environments. You are probably familiar with the concern that the direct care workforce is not prepared to meet the population needs, especially as the population is aging. There is a projected shortage. There was a small increase in the direct care workforce last decade, but unfortunately, it ended up representing a 1.5% decline in the number of direct care workers per capita. So there is concern that there is an inadequate supply of direct care workers to meet the growing need for direct care worker supports and services for older adults. And perhaps you've encountered this workplace shortage while you've gone to clinical sites or in your work. Some of the factors that contribute to a shortage of direct care workers are low pay for these jobs, patterns of discrimination facing the individuals who often work as direct care workers, and a lack of decision making in the workplace. It can be very hard to continue to work in a work site that doesn't value your input and insight into decision making. So, what types of factors can improve direct care worker retention? What have we seen in surveys? So, any types of interventions that help to improve leadership and staff empowerment, uh, any sort of decentralizing of of a rigid or hierarchical organizational structure, improving communication among colleagues. Direct care workers have also indicated on surveys that they find good quality training to improve retention, and particularly expressed concern about training that addresses health conditions or disease states that face the people that they work with, and also supporting direct care workers to participate in care planning. You may be thinking, why would a nurse be concerned with the direct care worker workforce? Certainly because you share a lot of the same individuals that you work with, right? It is very likely that the people that you care for, especially if they're older adults or people with disabilities or people receiving long term supports and services, also receive supports and services from direct care workers. And having a direct care worker can help improve their ability to live independently, perform those ADLs like we discussed on the previous slide. So it behooves the nurse to make sure that there's an adequate supply of direct care workers to help support the people that they also work with. And then you'll also notice on that last slide, we talked about all the places direct care workers work. Those are often places where nurses work too. So any type of intervention that improves the workplace culture, the organization and structure of the workplace, facilitates better collaboration and communication, is probably going to improve the workplace for the nurses too that work with the direct care workers. Um, so it's very important to consider what makes a good workplace for your profession as well as for the other people that work with you in your workplace. Also significant in terms of future directions for the direct care workforce. Here in Michigan, the state has recently approved 15 competency recommendations. So that just means that instead of the patchwork of acronyms that we talked about, along with that patchwork of acronyms, there's a patchwork of different requirements for training or credentialing among these direct care worker job roles. And some of them are time-based, some of them don't have very many requirements or recommendations. And so these 15 competency statements would indicate that people who are direct care workers have demonstrated proficiency in these 15 competency areas. And that will be especially important to nurses who work with those direct care workers to understand what roles, skills, and knowledge those individuals possess, as well as to professionalize and promote the work of direct care workers and improve the quality of care that the people they work with are receiving. So it's a very exciting development. Interprofessional collaboration. So that the definition there from the World Health Organization is the provision of comprehensive quality services across settings and disciplines by multiple workers. So that just means people working together from different otherwise siloed professions, right? Physicians and nurses, physical therapists and dentists, direct care workers, you name it, anybody who's working together. Similarly, interprofessional education occurs when two or more professionals learn about, from, and with each other to enable effective collaboration and to improve health outcomes. So, how do we teach someone to collaborate well, right? How do you learn collaboration? The Interprofessional Education Collaborative, which the American Association of Colleges of Nursing is a member, the Interprofessional Education Collaborative outlines 4 big competencies for interprofessional collaboration that we can work on learning. 1, identifying shared values and ethics for interprofessional practice. 2, learning and recognizing the roles and responsibilities of the different interprofessional team members. 3, establishing effective interprofessional communication. and for collaborating in such a way that you're doing interprofessional teamwork well, right? What does it mean to work together? So let's address the experience of working as a nurse who's participating in interprofessional collaboration. I have two columns here. Over on this left-hand side, you're going to see um, some nurse-specific competencies about working with other professions. And these will look really familiar to your NCLEX style practice questions where you talk about delegating to assistive personnel or reporting findings to a physician, right? Or maybe even performing those dependent nursing interventions, right? Doing something that was ordered by another provider. Um, and then on the right-hand side, you're going to see IPEC, those four competencies that refer to the whole team. So the nurse is charged with understanding and respecting the different roles of team members. Um, how that team works together is agreed upon from the outset by the whole team. Uh, as a nurse and all the other members need to participate in information sharing that's accurate and meaningful. And then there's a shared accountability among all the members of the team to an agreed upon value set. So, how are those two experiences a little bit different? Well, the nursing competencies just address the work of a nurse, but the IPEC competencies address the work of the whole team. So, it's really about shared governance, decision making as a group, and accountability, right? You have a role to perform that's in service of these other professions, and you can have the expectation that these other professions are going to help you as you perform your nursing responsibilities. Versus that left hand column is just about the nurse conducting their nurse work. And why is this so important? Because I think on this right-hand column, we're really creating a system that creates a whole network of professionals that surround the individual, right? Instead of surrounding just the nurse. And that brings us to our next topic, which is person-centered thinking. I keep talking about person-centered thinking, so let's define it. Person-centered thinking is the integrated healthcare services that are delivered in a setting and manner that is responsive to the individual and their goals, values, and preferences, and a system that empowers patients and providers to make effective care plans together. So, nursing care that's person-centered would be nursing care that revolves around the person rather than just responds to their disease state or the setting or the nurse, right? We sometimes go in with our agenda of this is what the nurse is going to do today. And then we go in there and do it because this person has this disease and this treatment and they're in this hospital. So this is how we're going to take care of them. Person-centered thinking instead says, what does this person need? What do they want? What are their values? What are their preferences? And have you asked them what's important to them? Have you made a decision with them, not for them? And you'll notice in this orange box the use of the word patient versus my blue circle, which uses the word person-centered thinking. And why is that notable? Well, because I like to think that a person is always a person, and a person is not always necessarily a patient, though sometimes they may be. It's important that we consider the person outside of our nurse-patient interaction. And I understand using the term patient because you want to define the boundaries of that relationship when you establish a nurse-patient encounter. But that patient isn't always a patient. Sometimes they're a person and they encounter their family members, their community, their services, their personal values, and their direct care worker who helps provide them with long-term supports and services. So you may hear direct care workers talk about the people that they work with as a person, an individual, or just call them by their name. They may not use the term patient quite in the way that we do. And I just like to think person-centered thinking. I take my agenda and put it in my pocket and really try to listen to the agenda of the person that I'm working with for that day, time, year, month, lifetime. So, what are some examples of person-centered nursing care? On the left-hand side, you're going to see asking someone what matters the most to you. What do you want from your care? Asking someone to tell me, what would you like to do in a day? Or how would you like me to support you? What would you like me to call you? Those are all person-centered questions a nurse can ask. Things that aren't so person-centered that we encounter in our profession, really strict regimented facility specific requirements like this is when you take a bath in the long-term care facility. This is when you eat breakfast. This is what's for lunch. This is how you take your medication. This is when we allow visitors. That's a very not person-centered list of rules and regulations, right? Those are very facility-centered or staff-centered, not person-centered. Anytime you hear someone described as non-compliant with their medications, my knee-jerk reaction whenever I hear that is to say, maybe your medication regimen wasn't compliant with that person's preferences and values because they weren't compliant. They made their own decision and they decided not to take those medications the way that they were ordered. So saying that they're non-compliant with their medication regimen misses the opportunity to learn what is a medication regimen that works for that person and have you addressed it fully instead of writing them off as non-compliant. And then finally, this other term is particularly a real challenge for me. I've heard this in maybe the hospital setting, where we're making plans for what do we need to do to take care of this person. And we see them having orders written. And then the last thing is we really need to get them to sign a DNR. And I know that the person who says that in their mind is thinking of understanding the prognosis of this person, potentially preventing them from having an unwanted adverse experience around their death, right? It can be very arduous to experience, CPR or full code when you have limited prognosis because of other illnesses. But just saying get them to sign a DNR really undermines the autonomy. The role for a person-centered thinking nurse would be to counsel people, to provide teaching and share information with someone, to support them to make the decisions about what they really truly want and what their values and preferences are surrounding end of life. And then the person-centered thinking nurse supports whatever choice that person makes. So where do we do person-centered thinking in these professional models? Where's the overlap? Just looking generally at our models, maybe this nursing meta paradigm is familiar to you. I know I say it all the time in nursing school, when I was in nursing school, right? That the person, their health, the environment, and the nurse are four factors that are always interacting and can never be separated or isolated or underestimated, right? We have to include all the parts in our nursing care plan. Very similarly, the direct care worker competencies all surround providing person-centered thinking. It's always influenced in a person-centered way. And then it gets into the different tasks performed by direct care workers, right? They provide functional supports and services, health supports and services, community supports and services, meaningful activities, and meaningful relationships. So you're probably looking at these and thinking, quite the same, but maybe a little overlap in terms of there's a person-centered element, right? We don't underestimate the significance of the person in the nursing meta paradigm. There's also significant consideration to relationships are so important. And the setting is important and influences what we do and what is going on with the person. Also, very holistic approaches, both of them, right? They value different elements. It's not just health. It's not just community or environment. It's everything, all of it, the whole thing. So let's talk about geriatric syndromes briefly, just to define the term geriatric syndromes. Geriatric syndromes is a term that describes a complicated series of problems that cross the boundaries of a single body system or discipline. Geriatric syndromes impact a person's quality of life and their functional abilities. You've probably taken care of some older adults with a geriatric syndrome. Here's a list of some that may be familiar to you. Falls and dizziness, cognitive impairment like dementia or memory loss, pressure ulcers, sleep problems, hearing and vision disorders or loss, urinary incontinence, weight loss or inadequate nutrition, and then constipation or fecal incontinence, right? Any kind of bowel challenge. And so those are those general geriatric syndromes. And then I categorize them. And why did I categorize them like this? Because nurses, direct care workers, and physicians all play different roles in addressing each of these categories, right? So over the course of your work as a physician or a nurse or a direct care worker, you're going to look at people who have trouble with getting around and providing the right amount of support to them to help them move and preventing problems that come from immobility like falls or weakness. We also work with people who have challenges with elimination, identifying people who have challenges emptying their bowels or bladder and making sure they get the necessary supports to prevent discomfort, to prevent illness, infection, or the loss of dignity, right? That's always a very important part of our work. We all work with overcoming the individual's barriers to consuming an adequate, preferred, nutritious diet. And then mind includes memory, thinking, and mood. So understanding the influence of memory loss, impaired thinking, or mood problems on the whole person, right? We want to make sure that we're supporting their physical self as well as their mental self. And then skin breakdown. All of our professions play a role in identifying the risk for pressure injuries and engaging in activities that preserve healthy skin and heal unhealthy skin, right? Nurses might do wound care, but they also may reposition people or provide hygiene to preserve skin. So, what are our different professional responsibilities to address the geriatric syndrome? So, direct care workers, when they work with people with geriatric syndromes, provide support for those activities of daily living and engage people in meaningful activities, as well as engaging in monitoring, reporting, and documenting activities about changes. Direct care workers have very close relationships with the people that they take care of and support, right? So identifying variations among in their responses to different care or treatment, the direct care worker is usually pretty attuned to that. And the direct care worker may also be responsible for initiating emergency responses in a lot of settings. Nurses care for older adults with geriatric syndromes by recognizing the impact of their current health status on the development and progression of geriatric syndromes. Nurses also develop nursing care plans that are informed by the required functional support, medical interventions, and the requirements necessary to meet the goals set in partnership with the person. And then physicians work with older adults. They take an inventory of functional status, and then they also select medical treatments that are indicated in the geriatric syndromes that are supportive, palliative, or curative in nature, right? So supportive means addressing functional barriers, palliative means managing the symptoms, and then curative would be like reversing the underlying problem that triggers one of these syndromes. Let's wrap up here with a little discussion about interprofessional communication. So when do we have to communicate with other professions? Whenever there's a change in condition, when there's an adverse event, maybe to report the response to a treatment, whether good or bad. When we're transferring care, either between people or between places, right? You might have to call a report. When we're trying to adopt a systems-wide change, right? We need to communicate about how we're doing that and rolling that out when we change a practice. And then also for work sharing, right? There's a lot of different work and tasks that need to get done by different people, and we need to communicate effectively to make sure all those pieces fall into place. Remember, effective communication is always focused and clear, and good quality and professional communication can avoid unwanted outcomes from misunderstandings or misinformation. So my first tool, I wonder if this looks familiar to you. I use it a lot of times with nursing students when they are learning to either give report or when they are calling physicians to make notifications of a change in condition. And I literally print out a worksheet and let them practice writing in on there, because sometimes those two activities can make a new nurse very nervous. I know they did when I was a new nurse, so I relate whenever my students are anxious about it. And I find that using this tool really helps because it sets up a template that ensures you close the full loop, right? It starts out with introducing who you are and who you're talking about, gives a brief summary, the headline of the problem, here's what's going on, gives you an opportunity to really think about what are the relevant background details to this situation. What do they need to know? Then give your assessment. What do you think is going on? What have you found? What's your belief, your judgment? And then finally, give a recommendation. Here's what I think we need to do. And when you give that recommendation, then you allow an opportunity for the person you're communicating with to agree, disagree, or provide you an alternative, right? So let's do a quick example. So I did an example where I'm a home health nurse and I'm calling a direct care worker. So I might say, hi, it's Bethany. I'm the home health nurse from such and such home health agency. I'm calling you about Mrs. Jones. I need to perform an assessment and treatment for skin and wound care on Mrs. Jones. Just a reminder, Mrs. Jones, as you know, has dementia. She uses a lift and a wheelchair. She's a 1 to 2 person assist with all of her ADLs. And she was recently in the hospital and she has a pressure injury on her bottom. So I need to make some decisions about addressing her decubitus ulcer with skilled wound care 3 times a week. Is there any way I can schedule a visit at a time where you'll be there to assist me with positioning her and helping her into the bed for a treatment? It'll probably take about an hour to perform the wound care. Can you also make note of her appetite for the next few meals? Before I come there, I need to know how she's eating. And then you have the opportunity for someone to respond with a good time and place, as well as whether either of those are realistic or unrealistic requests. My next tool are the cuss words, not not the bad kind of cuss words, but the good kind of cuss words that we can use in the hospital. So this is stop the line language, phrases that are universal, that are easy to understand, that can counteract, be used across, interpersonal dynamics and counteract any kind of challenging workplace dynamics where maybe there is perceived power differentials and it's hard for someone to speak up. And the goal is that it gives everyone the opportunity to speak up for potential safety events, right? So you would be able to say, I have a concern about this. I'm feeling uncertain, and then stop. This is a safety issue. Perhaps you've been in a situation where you've had to use this. I think all the time of some of them that I've been in, and usually it will get people's attention when you say, I have a real concern about this. And then someone will stop and let you expand. But the idea of having 3 is you can elevate the tiers, right? That when you get to this is a safety issue, then no one can proceed until you've reached some consensus. So an example might be a new nurse is concerned about a medication that the physician has ordered. And they say, I have a concern. I think she might be allergic to that medicine. And the physician says, well, it's not on her allergy list, so she's not. And then you would say, I am feeling uncertain about that because the husband told me that she is allergic to it. And they would say, well, if he was actually allergic to it, why wouldn't it be in the list? So we have to give it. And I would say, nurse, this is a safety issue. I can't give that medication until we can confirm the allergies, right? Right? Everybody has to stop the line, confirm for safety, even if you think you know better or the medical record doesn't match, everybody's not in agreement, right? So it's a good opportunity to use those cuss words. And that brings me to my personal recommendations for how do you deal with disagreements in the workplace, especially when you're crossing interprofessional boundaries and lines and working with people who might have a different background, right? We work with people who didn't go to nursing school and we bring our nursing school perspective to things, and it doesn't always translate well. So here's what I always try to do. 1, presume that their concern is in good faith. And then I always feel like the ability to clarify my rationale and use good evidence and explain why I'm doing what I'm doing has a great effect on the people that I work with, right? It confirms that I'm a trustworthy colleague for them. So that's always a good opportunity for you. Also, see the opportunity in double checking, right? Whenever you hear about someone who's made a mistake, they did not anticipate it. And so when someone disagrees with you, use that as the opportunity to do a verification and prevent a mistake. And then it's always good to get help, seek trusted sources, know who's a good source of support when you can't settle a difference with someone else. And then always make sure that you're sharing tools and access to good quality information. Thank you so much for all of your attention. I am so looking forward to meeting all of you, and I will see you soon. Thank you all for listening.